Hi, everybody. This is Erica Mello and Susan Clinton, and welcome to podcast episode number 86. And Susan and I decided this week to release another one of our really most popular Facebook Lives. A lot of them are popular. I know we always say that, but this was really interesting because we talk about neural tension. And the name of the episode is called Neural Tension and Beyond. And Susan and I talk a lot about neural tension throughout most of the podcast. However, we've not really devoted an entire episode to it. So we really think you'll get some great clinical pearls and you'll listen to how we clinically reason through some interesting patients. And we hope you enjoy it. And I know Susan has some information on our mentorship program.
Yes, thank you, Erica. And welcome again to everybody to podcast number 86. Hard to believe that we're rounding, having our ups and downs this year, but we've been here and we've been happy to be here all year. We are going to renew our very popular mentoring mastermind membership, which we started this year in October. We're finishing it up here in the next couple of weeks. We've had 12 participants and it's been just amazing. The calls have been amazing. Most everybody's had their one-on-ones, and we have an elite retreat coming up in a few weeks where we're going to be spending 4 weeks with the people who signed up for the elite level. And looking forward to doing a deep dive on patient case solving and critical thinking. So we're going to be launching that again, but you'll be able to read all about it in our newsletter. So if you're not a member of our newsletter, walk on over to www.toughtotreat.com and sign up for our newsletter. That's where you get the best, most up-to-date information. Yes. But we'll be launching that in January, along with some other exciting initiatives that we're doing. And our website, Erica, is getting a brand new facelift too.
It is. It's by a long time, and it needs it. So we've been. I mean, it's a decent. It's a great website. It's just I think that we really need to be able to, put our more information out there for everybody. And I think that you're going to really like it.
So anyway. I think that's everything. Enjoy the podcast. If neural tension is your thing, or you have questions about it, this is the podcast for you.
Enjoy, everybody. We decided this week to do it on neural tension. So for those of you who haven't seen our other Facebook Lives, we've done it on foot progressions, thorax and the breath, and the last week was knee, which was really interesting. And they all were interesting. So this week we decided to talk about neural tension, and it's a sort of a black box term. I think it's all about the nervous system in the end. I think, but in particular with people who have neural sensitivity or adverse neural tension, or there's something in their system that doesn't like to be lengthened, and so they react with quote unquote neural tension. So I will just give you an example of a patient of mine who I believe has, we've talked about her on the podcast, but one of the characteristics of people who I believe have a very heightened system is their inability to tolerate length. So for example, if they do like a down dog and they're fully dorsiflexed, heads drop, they're not happy. They're not happy. And this one girl, she has a hip issue, and I was working on her, her diaphragm and in her rib cage. All of a sudden, and she's in supine on the table, her right foot's inverting. And in how I've learned this whole system and this whole concept of neural tension, something that I was doing, I was trying to lengthen her in her diaphragm and her rib cage. And her right foot decided it didn't like it, or her whole system, and her body just said, "I'm going to turn my foot in because I need to shorten something to take up the length in the system." Does that make sense? Mm-hmm. So I think that positions that require a greater neural mobility, like a down dog, for example, are hard for people who have those, dare I say, dural, drivers or dural issues. They don't like, systems don't like length. So with her, she's inverting her foot. So I'm going to stop there and let me know. I just wanted to open up the conversation. If anybody has any questions, feel free to comment.
Yeah, so the thing that I think about with a lot of neural tension is the things that we talk about quite a bit, which is the fact that the nerves actually need to move. And I think everybody gets that in the periphery, that the nerves need to move in the, the long tracking nerves down the legs, the long tracking nerves down the arms, need to move. But a lot of times where they can get hung up may not be in the periphery. It may be more in the central trunk area. And for whatever reason, it could be just a habitual postural stiffness, from being in one posture all the time. The nerves have kind of shortened and adapted to that posture. And therefore, when we go and take them out of that, or we we change the posture in some way that puts tension on that whole system, then you might be getting some of the stuff that happens down the leg or down the arm. And I think oftentimes that's why we run into these people with insidious onset, that, they'll think, well, it's a nerve root entrapment, or it's a disc, protrusion onto the nerve root, which it could very well be, but it also could be just prolonged lack of mobility, from postural, habituation. So, if they're sitting at the computer all the time with, a certain particular habituated posture, that over the time when they start to, so if they're first starting to do it, it's not going to be a big deal. Right. But if they're doing it day in and day out, 8 hours a day, 320 days a year, eventually they're going to habituate to those postures. That's just going to be their movement system sets that way. They, they have more trouble moving out of it, because as they start to go and as they start to move, then you start getting a lot of that tension pulling on not only ligaments and muscles and, those things, joint changes, moving the joint in a different position. The nerves are, going to holler and fire at you too, because they're used to being in a different position. And so when we go to move in those other positions, that's oftentimes the time people will complain about, that's bothering them. And then the other thing that you talk about all the time, Erica, is the fact that, nerves, run with arteries and veins, and they need a lot of oxygen. And if we don't keep, the entire neural system mobile, they get sticky and stuck, and, they just don't, they get a little, I don't know, it's almost like they don't have the same kind of like soothing myelin kind of conduction anymore, that it may work in a shortened position, but as soon as we start to lengthen it out, we're kind of stressing and stressing tissue that is kind of adaptively changed a little bit. And we have to, and that's where I think all the tensioners and the lengtheners and all the other language that everybody talks about comes on and really begins to show itself with certain things. So if people keep their arms down all the time, and then we go to actually have them put their arms up, we may run into like, ooh, that really bothers me. And it doesn't really have to necessarily also be lancinating pain down into the extremity. It could be like what you were talking about. It could be that you see that they just can't get their like they can move their wrists all around, but as soon as we put them into this position, they can't supinate. They can't, supinate. They can only they can only get into pronation. They can't get into, the open supinated position.
Right.
So their hands start, like you were talking about the foot everting, the hand starts pronating as we kind of bring them up into that position. And it's because, it's just the system is going to take the path of least resistance, of course, because it's more comfortable.
Yes, of course. I think that, of course, because people like that, especially with a history, there are certain things that I like to look for in a history that may lead me to believe that yes, not straight neural tension as in a positive slump test, but your neuromobility has been compromised. And for me, the few of the characteristics are significant injury history. And I'm, significant. And whether it's a fall onto the coccyx, or, multiple sprains in their ankles, or herniated disc, there's definitely a history of long injuries there. Also complaints, in my opinion, of cramping and sort of fasciculations. Like some people say, I cramp a lot. I get the cramp in my calf. I get the cramp in my hamstring. I find that also a character, in that history. Also, pain, not so much pain, but paresthesias that don't necessarily fit that radicular pattern that you would see with an acute disc where it's down the side of their leg into the calf. These are paresthesias everywhere. Also, pain in multiple body parts. For example, recently I had a guy. I was doing it virtually. I was showing him how to do a slump slider for his home program, and I felt that an issue. He had multiple concussions, so I thought that his neck and above was part of the issue. So versus the straight dural neural issue, I had him do some imagery in his head, like soften the muscles at the back of your hairline, which is a great cue for them to sort of relax those suboccipital muscles. So before I gave him the cue, I had him do a slump, normal slump, head drop, flex, knee extension, a dorsiflexion. That was his baseline. So when he did the imagery of softening the muscles, I said, keep that imagery and now redo your slump. Just on the right leg, it was way worse. And I had him repeat it twice because I was like, I wasn't there physically, and it was way worse. So based on that, I said, well, jeepers, I don't particularly think the neck is that, he's making, if I were in the clinic and I started to work on his mobility in his neck and do some work there manually, I would make that neural tension much worse based on what I just saw, that little piece, right? So in those situations, do you treat the nervous system, via, like a slump or a straight leg raise or sideline? There's multiple ways you can do it. Or do you actually go in and work on the neck? I would not work on the neck based on that. I would make them worse. So, your thoughts, any?
So my thoughts always my conformational bias is to try to see what the system can do on its own.
Yeah.
So especially when it gets a little complex like that, I like to get the system moving in some other ways. So rather than taking them into the direction to where they're symptomatic or they're not able to overcome or recoordinate or shift or do whatever it is, they're just not accessing that particular movement pattern. My bias is to go and try to find movement patterns that they can access and see if we can't get those moving more, and then go back and see what happens to that one.
Yeah.
And and oftentimes, we've talked about this on the podcast a lot. Oftentimes when we go and do that, even indirectly, you're talking about the head and neck. My thing would be, let me see what I can do from the bottom up.
Yep.
Let me see what I can free up from the bottom up. So that would be somebody I would perhaps lay down on their back and have them put some straps around their feet, both feet together, and bend their knees up and just kind of work on, straightening those knees up and down and maybe going side to side and turning the feet, really winding the system up from below to see if it might help begin to it's a novel input to the system. I wish we could say, we know this does this because it does this to that, and we don't know that.
Right.
But I do know that when we do these kinds of things and then you go back and retest them and they're able to access that motion better, there's definitely something in the nervous system that's changing. We just don't know what it is.
Right.
And so to me it's like, well, if it makes sense that if we can get the system moving in some other parts, that begins to be a novel input to that system and maybe kind of changes the movement pattern that they already have kind of laid down following that accident or injury, rather than just going into the area that's already sensitized from an injury that they may be protecting against. It's kind of like going around the side door or the back door and kind of knocking gently at that to see if you can kind of get that system to respond there, rather than, hey, let's slam open the front door every time trying to open this. I don't know if we did a podcast about this or not, but I had a gentleman who was having trouble with a particular yoga pose, pigeon, for those of you who know yoga, but apparently that's a lot of flexion, external rotation, abduction of the hip, you know, the leg crossed up underneath the body, and he just felt like his hips were continually a problem and super tight all the time. And, you know, when you get into that position, there's some lumbar flexion that's, you know, because you're flexing over the leg as you lay down prone, you know, and trying to kind of just, and, you know, he was thinking that it was because he can't stretch out the leg that's long. It was the other leg, or he can't get over it. He really was having difficulty with that, and that was really bugging him, and he wanted me to take a look at him and see what we could figure out. And I know a lot of people are thinking, well, you know, just get in and mobilize the hip, then make it work a little bit better. And that makes sense, but he was already doing that.
Right.
That particular position over and over again was kind of a joint mobilization, but it just wasn't making, I mean, how many times has he tried to do this position? He does joke every day. Yep. And it wasn't getting any different. And he was kind of like, besides modifications, I know I can slide a folded blanket up underneath my pelvis, and it's a little bit easier to gain the motion, or, you know, to not feel so tight or uncomfortable in it. What else can I do? So I just kind of took a look at him and took a look at his back, and I thought, I wonder what would happen if we got the back moving differently. So I could tell when he was moving around and stuff, he just wasn't, you know, it was uncomfortable for him to gain a lot of back extension. You know, and he, you know, he could bend over pretty easily, so he could touch his toes. You know, he could move pretty well, but it was just that particular position that he couldn't do. So I just started thinking about, what can we do with arms? What can we do with the back? What can we do to kind of, you know, get things going a little bit differently? And so I just basically took him through kind of a bit of a McKinsey, I shouldn't call it a McKinsey protocol because I'm not McKinsey certified, but I took him through a positional, repetitive positional program just real quickly. I had him start by just laying on his tummy and just doing some, you know, press ups, and leaving his, you know, low back down, you know, so we could get some work through the arms and the upper trunk, and just trying to gain some, just to see what would happen.
Yep.
And so we did those a few times, and then he got back down on the floor and repeated the position, and it started getting better. So we just kept doing that, and he got better and better and better and better. And what he finally decided was, he goes, I've been going about this all the wrong way. I've been trying to do more and more of trying to bend over to get this position, rather than trying to take it into an extension. And this guy, when you know, and I should track back 1 second. One test that I did do was a femoral nerve tension test. I just kind of basically did that Eli's test just to see what the resistance was there. Eli's test: on your tummy, bend the knee up, raise the knee up, you know, bend the knee back, raise the knee up. You know, if it's a tension test, you should feel it in the front of the quads. I mean, he said, yeah, my quads are tight. It wasn't anything lancinating. It wasn't all of this stuff, but, you know, it wasn't like he was lacking a ton of hip extension either. It just, for whatever reason, the position that he's in all day long is sitting. But he is a mover. He does yoga, he does racquetball, he does all kinds of other stuff. And so it was interesting to kind of just take it out of that whole flexion type of piece, and forget that we actually have a whole bunch of nerves that run down the front of the body too.
Yeah.
And for him, one of the things, where he was getting hung up to me was not on the side where his hip couldn't flex, externally rotate, abduct, you know, do that kind of cross up underneath his body thing. But it was the other side where he was having difficulty gaining the length to come down. So he was actually rolling over on that side where the leg was bent up underneath him.
Yep.
To get into that position and stay there, and he wasn't getting anywhere, you know, because he kept doing it and it just wasn't happening. And once he could gain the length on the other side, so like say right leg was bent up underneath him, on the left side, then the right leg began to relax and change.
Yes.
But it was fighting and holding probably, or, you know, whatever motor pattern was going on was protecting, because it didn't like that whole system being lengthened.
Right.
You know, but he didn't have pain. That was a thing. I wanted to kind of bring that up. It's like, is it neural tension? Is it stiffness? You know, but it changed so fast. So it can't be collagen stiffness.
Yeah.
It can be habitual holding patterns, though. And I think the nerves are part of that, you know, because, again, the habitual pattern for him is sitting.
Yeah.
Even though he is a mover, you know, he's spending a great deal of his time sitting. And so, you know, kind of just thinking about that is pretty interesting. And, but it was fun because just doing those press ups, you know, by the time we finished, I think we ended up doing 10 sets of 10. And by the time we finished, he was pretty comfortable on both sides and he had gained a lot of motion. So this wasn't a joint issue.
Absolutely. Very interesting.
There's a movement issue, you know? And so just kind of thinking along those lines, that's why I thought about neural tension, because it's like, it's not always, it doesn't always have to bring pain on, but it can be restricting. And, you know, when you think about the nervous system and how fluid it is, and once we can kind of get things moving. And so instead of going into the hip, you know, I just went into the back, you know, and let the back start, you know, the trunk start gaining, had him bring his head up even, you know, just kind of anything to kind of start thinking about that whole anterior, you know, chain, if you will. I probably, you know, I wish that I had had 2 of him, because it would have been fun to have done, okay, this person over here, like you know, like a set up an experiment. This person over here is going to do press ups and then regain the position and see how it goes. And this person over here is going to do trunk rotations.
I love it.
And see, you know, but I didn't, you know, I wanted to stay with one thing because I wanted him to have something simple, and this was making a difference. So we just stayed with it, you know, so he'd have something simple to do prior to going into yoga class. And he felt like, this is what I need, is this warm up to get me going so that when I get prone, I can do these things. But I think the trunk rotation would have worked just as well, because if you think about it, all the, you know, ilio-hypogastric, ilio-inguinal, ilio, whatever, all of the genital-femoral all come down through the anterior, you know, through the front and, you know, across. And so maybe, you know, specifically it was those that were, you know, kind of being hung up a little bit.
You're talking rotation in what? It's anything.
Yeah, for me, I would have thought about really rotating the upper part of the body. You know, just really, really getting that going. I wouldn't mind if the hips went with it a little bit, but what I was trying to do was, you know, what I was thinking of is that if I could get something else to move, you know, to change up above where he was not, you know, feel, you know, up above the hips, that I would want to see how he reacted, how his system changed in the face of that movement that we introduced. So, and I didn't have a chance to like compare the two, because, you know, he was already, so if we had a rotation, who knew? He was already doing better with this. So one would have washed the other out. It would have been like, okay, so he did both and who knows what worked, but he really liked the one. And so we stayed with it, and it was making changes for him.
Yeah, I think that's fascinating, because, you know, the right side, you often think, and I know we always often talk about this on the podcast, you need to look at the other side of the body, you know, if not just for comparison, but in this particular scenario, he didn't like that right side wasn't lengthening, and because the body didn't like it, it was shortening at the opposite hip, and that's why stretching the heck out of the hip certainly doesn't help. And I think that's a great clinical reasoning, clinical pearl, for lack of a better word, because if someone's stretching or mobilizing or you're doing whatever to gain some sort of mobility and it's not helping, look at the other side of the body. Is there something that doesn't want to be lengthened? Try some of these neural tensions. I like a good one in standing, where you just a quick screen where you do a stand, and then let's say you just stick the left leg out in front, and you sort of do a Japanese sort of waiter's bow, and you dorsiflex your foot. So left foot in front, and you're just sort of, you know, you're sort of basically getting it, feeling the hamstring, obviously. Then I check the right, and I see if there's a difference. So I use that as a quick screen in standing to see if whatever I end up doing treatment wise in the first visit, or even if the evaluation had a treatment effect, I recheck that. So I just call that like a bow with a straight leg raise. And I do that fairly often. You know, and I also have, I like the prone knee bend and the extensions. I also do in standing. If I see somebody, and I'm thinking about this guy that I'm treating now, he squats and he's, you know, we've talked about him before. I think he's going to be our next podcast, actually. Multiple issues everywhere. And he squats, he goes right to the right. I mean, obvious, right? So I'm taking some tension out of his system. I put a half foam roller under his heels. I'm shortening his feet. his calf.
Mm-hmm.
So when I have him squat on the half foam roller, he's much better. He doesn't look perfect, but I'm giving his body the ability to adapt and shorten at one end just to see how he looks. And he does look better. There are other ways that I've done, especially like in supine. I love the lower trunk rotation. And, it's funny, as an aside, David Butler came out with a video this week. I saw it actually here on Facebook. He's talking about everybody sitting and how they need to be doing this in front of the computer and this and midline and this and dancing. And I mean, I was laughing so hard. It was so David Butler, but it's a really good word, words of wisdom. So with this guy talking about, I often see that when I have my hands on their head. So I don't know if you've experienced this. If I'm working on somebody's neck, for example, and I want to release some muscles in the neck via some lower extremity movement, I'll have my hands on their head and I'll have them do some lower trunk rotation or some heel slides with dorsiflexion, and I'll feel a huge pull in their head. It's like the Bert and Ernie head where the turtle is sinking into the shell. Mm-hmm. I often feel my hands, I'm just having them do a little bit of a chin, a little nod of their head. So they're not lying like this, right? And then I have them do a straight, like a heel slide with dorsiflexion. And all of a sudden, my hands are gripping like crazy to keep their heads from sliding down the table. That's a neural restrict. That's neural tension mm-hmm. in my mind. Whether, they're not experiencing, once again, like you said, lancinating pain or any kind of paresthesias. Their body doesn't like to be lengthened in that position. And it's right there. It's their neck. I'm intervening at their neck, so they're shrinking. It's like the turtle that's going into the shell.
Right, so, being pulled this way, from the system, whatever the system is choosing to use, but it's being pulled down and in. And, but it makes for an interesting thing for the people who cannot sit up and straighten their knee and do the head things. Just being able to lay flat and be able to just drop the knees down and get to where they can drop the knees down and bring them up, and then maybe add the feet and the knees together. Mm-hmm. And then, the lengthening of the head with it, so it's almost like a mini cat-cow laying on your back, but just starting kind of, choosing to start maybe at the knees and the feet rather than up at the head, or start at the head and actually add the feet in wherever you want to go with that.
Yeah.
To see if you can get that, easier for them. To move through, which would be very interesting to do. And it also reminds me of one thing I wanted to talk about here, was that I think neural tension changes when we get under gravity. And what you just said made me think about that. And I know we've kind of discussed this before, that somebody can have a slump test and look pretty good. And then you put them in that Japanese bow position with one foot forward and they can't do it. And I think it's because we're loading the system too. Mm-hmm. So maybe they can passively work on getting that foot back, but when their body weight comes down on it into that dorsiflexion, the one behind them, and they're adding the body weight coming for, leaning down and really, tensioning that system in that way. I think that has a lot to do with it. I think sometimes we miss it because we don't look at it in those ways under gravity or under compression. And one thing you talked about once upon a time was somebody with a shoulder neck issue, and you had them on all fours and they were having trouble coping with it until you reached underneath them and just kind of like lifted their pectoralis up. Basically what you did was unweight their brachial plexus. You just brought it up and got it out of a tension position and just lifted it slightly. And they were able to really kind of relax down into their arms. Mm-hmm. And we were talking about that. I think I remember on the podcast saying exactly like you found a neural tension problem in their upper quarter for sure. But this was one of the things with this person was that they had some good movement, but it was when they got into, like arms on, on the floor, those kinds of things really bothered them. Yeah. And that was when, when the body added, weight bearing onto it, it became too much for the system to really be able to, the extra passive pressure was more than that, system could handle. Yeah. And I think that's important too.
Yeah. I mean, I think that in school that we've all learned over the years, testing for slump and straight leg raise for herniations and things like that. I routinely test the slump. and that Japanese bow, with or without any history of disc or paresthesias, I do routinely do that. Just because you have neural, just because you don't have nervous, numbness, tingling, doesn't mean you don't have neural tension. I mean, I think everybody has neural tension at the end of the day. I do. Our bodies are able to cope with it. And the people who you see this inversion of the foot, the turtle in the, in the thorax, or the turtle
lack of supination of the arm when you're going up,
hip restriction, those people, you can compensate until you can't. And then you have to think about with their history, they just don't like to be lengthened. And I will tell you, a lot of times you can pick them out from their history. And I also, not because I always tell people that, if they're doing a slump or a prone knee bend, or, lying on their back and doing internal rotation, straight, knee extension. I often do a lot of this where they're supine, arms like this, so their arms are straight, and they're doing trunk rotation, and they're opening their arms out like this to the side. I do a lot of that for people, and that is, I tell them those are neural glides, but at the end of the day, I don't necessarily, I say you don't have a nerve issue. It's your nerves are bloodsuckers, they need oxygen, so they need to move. And that's the
all the tissue to be going, and the nerves come all the way out to the skin.
Right, and so and so I think as clinicians, we should test. It could be anything. You could do ulnar, radial, median. You could do slump, thoracic long sit. You could have them squat, do a adapt, anything that requires lengthening of the system. I think we should try this as just a test. It could be somebody who has knee pain. do a neural tension test, whatever you want, before in your evaluation. Treat whatever you find where you find the driver is. See if that neural tension piece got better. If it did not, then there's something you've missed. Even though they say they feel better, recheck that, because I guarantee you there's a piece of the puzzle that you missed.
Right, or you could leave them with that to let their system kind of percolate and marinate, and then come back and see if anything else was unmasked, or maybe it just, because it's been going on for so long, it gets better, when they have a chance to kind of have a little consistency of that novel movement that you've given them, which I think is also super important. And as we're talking about lengthening of the system, remember that the more we cross over midline, the more we're going to encounter, a resistance. Because, if we're kind of going out, away from the body, we're going to have less neural tension. We just are. It's also unpacking and open packing the shoulders and the hips. So we're kind of hanging out in a little bit more open pack position, which is comfortable as well. But when we cross midline, especially of the lower quarter, that's when, sometimes you'll see that people may be having trouble with parallel squat, and there's no way they can even stand and cross one leg over. And if they start to bend, it's all over. It just doesn't work for them. And so kind of thinking about, wow, how can I get this person more together? Like maybe they need to have their feet apart for squatting for right now, because it's more comfortable and they can continue to move. But eventually what you want to do is say, let's start testing, retesting, if we can get you in a little bit closer, how far can you go? And can you play with that end a bit? Can you move your head with it some? Can you do it with your arms up some? Like just challenging the upper part of the system as they begin to stress the lower part of their system.
Yeah, it's like you're combining all the different tests into one movement, right? And there's ways that you can take out the feet. I just do it on the half foam roller. There's ways you can modify, the squat, like we were just talking about, narrow base of support versus wide base of support. Whatever movement they have a problem with, test it with narrow, wide, half foam roller, or no half foam roller, or put the ulnar nerve on tension and see what that does. Obviously the person can't be irritated, or, they have to have their system has to be able to tolerate it. And that's where the clinical reasoning comes in. You're not going to, have them, if they're really wound up in their ulnar nerve, you're not going to have them keep doing this. You're going to pick something else to as a test, retest. Those are ways of incorporating the base of support, the feet, and just some easy. I remember in one of David Butler's books, I think it was his DVDs he came out, he talks about a lot of these, radial nerve, giving them the tip or the median, the free the butterfly, and ultimately what we're doing in all of our movement programs is we're shortening and lengthening nerves ultimately. But I think some really good clinical pearls are, when you're evaluating them, see if you can take tension off with an easy base of support change, or half foam roll, or put, just do something with the,
or pillow under their knees, or maybe just a small little flat towel under their head. Anything that can kind of radically begin to start to change that a bit as they're doing their movements. Can you think of how many shoulder patients that you may see that simply just putting either like a small pillow under their knees, or just just a small support under their head as they're kind of doing some of their movements, how that might free up that system to begin to take some of the protection away, the overprotective part away, and free up some movement there. And then you could actually bring their head down further, as you go, or take the pillow away from the knees somewhat. So whenever I see people, that, will be working on, they'll lay down and show me some shoulder stuff. And inevitably, every single one of them bend their knees up and put their feet flat on the bed, which I don't have a problem with. But it makes me always think, why are they taking the tension out of their lower body? Is that the only way they can gain this movement in their upper body?
Yeah.
So it became kind of a thing that I got curious about. It was like, let's bring your legs down. Now what happens? And sure enough, they were losing range of motion in their upper quarter. And it was like, okay, so this person had been carrying around shoulder issues, shoulder pain, whatever, for a very long time, had habituated to a lack of motion in certain ways. And one of the ways they compensated was to be able to get their arm out, was to get their arm up, was to bend their knees up. So they just, but again, the system kind of does its own little self-correction piece, because they learned that it was easier. And so, okay, well, let's graduate down a little bit. Let's put a couple of pillows under your knees and let's try it. And then let's work with that barrier for a while. And then let's get another pillow out and let's bring that down, because now we're lengthening that lower part of the system as they're still working and coping with adding these movements to the upper part of the system as well.
Yeah.
And I think that's one of the reasons that they can, because I have always heard this story, well, it's easier because the scapula is being supported to lay on your back and lift your arm over your head. And I think it's because they are just they've unloaded the neural system.
Yeah.
Laying flat on their back. And I think when they stand up, again, we move into, okay, we're in dorsiflexion with the legs planted and the trunk is loading. And now that system the loads on that system are different.
Yeah,
it may be, we're raising against gravity, but we're raising against gravity on our backs too. So it was kind of like, I don't know
how your feet react to your center of mass and your center of gravity, and the pull from the floor. And it reminds me of a patient I had. This was some years ago, but I'll never forget him. He had a raging disc. I mean, this guy was irritable, your typical sensitive system. And he had been, I probably was his fourth physical therapist at that point. And, I don't, it wasn't an acute issue, but it presented like an acute issue. It was about 4 months. So I did do a little bit of a slump, not a lot. I don't like to sort of do it with those types of symptoms initially, but I did a straight leg raise, and it was just, crazy positive. So I had him do a squat just onto the floor, and on a wall squat, and his head was doing some weird thing. So I got him in supine with his knees bent over like a pillows, like you said, and I was just doing some things with his neck, and I felt, just this comes with clinical experience and just seeing a clinical pattern. I literally had him with the 2 pillows underneath his knees, just straighten one leg out, just very small knee extension. And I felt this huge pull on his neck. To make a long story short, I ended up treating this guy's neck and restoring mobility, doing some movement with this lower quarter offloaded, and then progressing to load some trunk rotation. But I really worked on some neck mobility. And that's where he lost options in his neck when I saw him. He may have had scarring in his lumbar spine down, but I was the fourth person he saw. So by the time he got to me, he had developed compensations, and his neck lost the ability to adapt to the lengthening system. So I did a lot of that pillows under the knees. And I think that people, even if you're the first person they see and they're that flared up, you need to sort of take tension out of their system.
Yeah. How can we unweight the system a bit so that it can begin to heal, change, and cope a little bit,
right,
and gain some movement rather than forcing it into positions that it just, for whatever reason, the brain may be protecting against, or it just may be something that they haven't thought about, or they just, have habituated in another way. And so they've kind of lost that movement pattern strategy. And we need to kind of begin to, as Corey Blinkenstaff would say, find the edge,
yeah.
and, and find where they can actually move, and let them explore that, rather than, if you can't move here, never move here.
Yeah.
But where can you move here that's comfortable? Because then as that edge will start to change, but maybe not just going straight out here. Oh, I can't do it, so I won't go that way anymore.
And we've all had patients
and helping our clients do that.
Yeah. And we've all had patients where movement makes them feel better. And why does it make them feel better? Who knows? Lengthening your nervous system. Who knows? Whatever. Yeah. It makes you feel better.
So that it works.
Exactly. Doesn't, your joint all of a sudden didn't get unstuck. I mean, your nervous system adapted, and that's the beauty of it all. So, do we have any questions or anything? I'm actually able to see Facebook this week, but I don't see anybody.
Annie's here. There's been a couple of other people in and out. Thanks for joining us, everybody. But no questions right now. If you're listening to this later, feel free to drop in and add some comments. We'd love to talk to you. And we will see you, soon in another podcast.
Yes.
Oh, and probably next week on Facebook Live again.
Yes. Anybody has any,
anything you want to talk about?
Please write post in the group. We would really appreciate it.
Yeah.
Bye, everybody.
Okay, bye.